the initial examination and periodontal treatment planning. In this lecture, you will learn the importance of a treatment-focused periodontal diagnosis and how to quantitate bleeding on probing and determine an accurate periodontal prognosis. This particular video is especially designed for teaching undergraduate dental students how to perform and determine these factors. This is the score sheet that is used, and you will notice that it is divided into 6 sections. The first section is on clinical signs of periodontal disease, and I think this is a little bit different and I think will be very helpful to the student. Certainly the first thing they should do at the initial exam is palpate externally for nodes, things of that nature, as well as looking underneath the tongue for any signs of oral cancer and so forth. And once that's done, we want to look for tissue changes. And one of the things I want to emphasize, this is before probing is done. They need to look for redness, edema, loss of papilla, fibrous tissue, absence of knife edge margins, enlarged tissue, blunted papilla, and frenal involvement. The next thing that they want to look at is using the periodontal probe to look for gingival defects. Is the gingiva attached? Is it unattached? Is there recession and bleeding on probing, which will be the next factor that we will look at. We also want to look at clinical attachment loss, and this is recession plus probing depth that gives us some idea of the amount of bone loss. Predisposing factors are etiologic factors. These can be broken down into those that can be eliminated, those that can be controlled, and those that can be altered. And you will notice the double asterisks are by those factors that are under the control of the patient. But look at those that can be eliminated. Defective restorations, but then you look at open contacts, uneven marginal ridges, plunger cusp, and food impaction. These also are things that can be eliminated. And by having mounted models, the student can look in there and actually use the models to help look for things like plunger cusps. Ill-fitting prosthesis, we can replace that. And as I pointed out earlier in the MMPPI scoring system on the index, smoking was the most significant etiologic factor on that. And another thing that we're beginning to see in the last few years is the damage done by intraoral jewelry. And certainly there are various aspects of occlusal disease which will be addressed in another video in this series. The things that can be controlled: plaque, calculus, and systemic factors. Systemic factors such as controlling diabetes, dilantin, calcium channel blockers that cause gingival enlargement are things that can be controlled. The things that can be altered would be the diet. For instance, the patient may have a high carbohydrate, refined carbohydrate diet that is contributing to the amount of plaque, and that can be reduced. And certainly the trauma from a toothbrush could be altered as well. Quantitative bleeding on probing. This is an excellent way of teaching dental students to evaluate bleeding on probing. Slight means there's a trace. It's delayed and means there's a minimal amount of inflammatory response. An example of this, you're probing on the lower left, and after probing number 18 and number 19, you notice a little blood has oozed out. This is delayed, probably not that clinically significant. Moderate means that it is spontaneous, means there's a greater inflammatory response, and in all probability, much more significant. An example of this is you are probing and you get a 5 millimeter probing depth, but as you're probing and withdraw the probe, blood follows that out. Severe is when we're dealing with profuse and persistent bleeding on probing. In other words, you have that same depth that we mentioned on moderate, but as you begin to probe before you even reach the depth of the pocket, you begin to get bleeding on probing, which is more profound and much more persistent meaning that there's even greater inflammatory response and hence much more significant. The treatment-focused diagnosis. Actually, there are four that we have. One is health with attachment loss, one is gingivitis, and one is periodontitis. We all know what health is. This is basically a prophy. But health with attachment loss has been somewhat controversial because this is where you have recession and attachment loss following periodontal surgery or other periodontal treatment. Health with attachment loss means there's an absence of inflammation, and this is healthy. However, if there's inflammation present with attachment loss, then this becomes a periodontitis. Gingivitis is certainly a disease, and we need to know whether it is generalized or localized. And with a periodontitis, we want to know if that's generalized or localized. But with a periodontitis, we're concerned with attachment loss. And slight periodontitis would mean the probing depth is approximately 5, moderate 6 to 7, and severe periodontitis would be greater than 7. Is it localized? And is it slight, moderate, or severe? So let's look at a typical diagnosis, treatment-focused diagnosis that we would see in our dental clinic with our dental students. There would be a localized gingivitis in the mandibular anterior area, and there would be a localized slight periodontitis in the molar areas. Now you have the diagnosis. Now you also have the treatment plan. With the gingivitis, as we're going to see in a moment, we're going to go in and do scaling, oral hygiene instructions, and reevaluate the patient at a later appointment to see that the disease is under control. With a localized slight periodontitis, first of all, we know this is not going to be a surgical case, and the primary treatment is going to be root planing with reevaluation. So, to summarize that, with health, we do a prophy, evaluate oral hygiene, scale, and polish, and you're done. With a gingivitis, you're going to do exactly the same thing, scale, polish, but then you're going to have the patient back to reevaluate because you've been dealing with a disease situation. Finally, with a periodontitis, oral hygiene instructions, supragingival scaling to remove any calculus, but the main treatment is going to be root planing and then reevaluation. Now below we have some significant information. Remember, a tooth has a lingual surface, a biting surface, and a facial surface. This is the area that is cleaned by the toothbrush. That's 60% of the tooth. But also there's an interproximal area where you cannot reach with a toothbrush, and this is the area where we floss. So 40% of the bacteria that are around the teeth is in the interproximal area. So let's say you do a really good job of brushing and flossing. Are there bacteria left in your mouth? Unfortunately, yes, because 90% of the remaining bacteria, which remain after brushing and flossing, are found on the posterior 1/3. Treatment for bad breath. This is very much associated with the tongue, but once you brush and floss, using a tongue scraper to remove the bacteria on the posterior 1/3 of the tongue. This area of the tongue contains sulfur-forming bacteria that give off the aroma or smell of rotten eggs. There are many tongue scrapers out there, but the one that I like is the tongue sweeper, which is made by BioCurve Medical. We see the website and we also see the 800 number. This was designed by Dr. Robert Rippich, who was a mechanical engineer before he became a dentist, and there were many prototypes that he made before he came up with his final design. So we see in summary here the 6 categories that need to be dealt with on a complete periodontal exam to come up with a treatment-focused diagnosis and a means of treating bad breath. Summary. The clinical signs of periodontal disease. This is where the student is forced to look at the tissue prior to probing to look and see exactly what the tissue looks like. Then they pick up the probe and determine things like, is the gingiva attached or unattached? What is the probing depth? Is there bleeding on probing? Predisposing factors, the etiologic factors. You will note on the score sheet that most of these factors can be eliminated. Finally, quantitative bleeding on probing. I think this is a very significant factor and has proved very beneficial in helping students to understand the concept of bleeding on probing as it relates to inflammation. The treatment-focused diagnosis. As I've said over and over, this is the linchpin. This enables the student to see not only where the disease is present, but also what areas need to be treated, and actually can tell the student exactly what treatment is necessary. Finally, treatment options. We've been through those. Finally, treatment for bad breath. Remember, 90% of the bacteria that are left in the mouth after brushing and flossing are on the posterior part of the tongue, and this cannot be removed with a toothbrush. You certainly have to use a tongue scraper. By using the information on this video in the periodontal clinic when working with dental students, I think you will find that they will find it a much more positive experience because they understand what they're trying to accomplish so much better than in the past, and they will view their time in the clinic as a positive time rather than a roadblock.